Hello, my name is Shahada Balanain and I'm the correspondent for MedEdge MEA at the 7th Emirates Pediatric Hematology and Oncology Conference. I'm honored to be joined by Dr. Scott Howard, an expert in pediatric leukemia treatment, to explore how we can better manage toxicities related to asparaginase therapy, which is one of the backbones of pediatric ALL management. Hello, doctor, and welcome.
Very nice to be here. Thank you.
Very nice to have you. Can you please kindly introduce yourself to our listeners?
Yes, my name is Scott Howard. I am a professor of pediatric oncology at the Hospital San Juan Cadeo, Barcelona, Spain. And here, sitting right now in the UAE in Abu Dhabi, enjoying this wonderful conference.
Nice to have you here. I'm happy that you're enjoying it. How are you finding it so far?
Oh, fantastic. It's just so many old friends that I haven't seen since the pandemic. So it's especially good reunion after 4 years.
Yeah, meeting old friends and hopefully connecting with new ones.
Exactly.
Okay, to start, Dr. Howard, for those who are less familiar with the asparaginase, can you tell us why it's such a critical drug in the management of pediatric acute lymphoblastic leukemia?
Yes, it's kind of interesting because when you think of categories of chemotherapy, there's cytotoxic chemotherapy that just kills dividing cells. There's other chemotherapy that kills cells when they're trying to create new DNA. And asparaginase is unique, actually. It kills cells by starving them of the amino acids that they need to survive, asparaginase. So it's when you add up the different mechanisms of cancer resistance, you have to tackle every single one to successfully cure the patient. So asparaginase added to the others is really powerful. And in fact, when you have no asparaginase, 20% more people relapse.
Despite it being really powerful and an important agent in the management plan, why does it pose such a toxicity risk or create a challenge in the treatment?
Yeah, and it's not that it's so much more toxic than other chemotherapy, but the toxicities are quite different.
Okay.
And so it makes sense that if it has a different mechanism to kill the cancer, it also has a different mechanism to damage the normal cells. And so the toxicity list is really a long one, but basically anything that requires a protein. So insulin is a protein, so if you don't have enough insulin, you get diabetes. The antithrombin is a protein. If you don't have an antithrombin, you get thrombosis. So thrombosis and diabetes and risk factors are problems that can happen with asparaginase. And pancreatitis, which is what we focused on mostly during this conference because it's one of the most feared complications.
Thank you very much for clarifying that and also highlighting the frequent toxicities associated with asparaginase. Now, for clinicians listening, what are the early warning signs that they should be on the watch for when they're treating patients with asparaginase?
It's so tricky because, of course, each toxicity has its own early warning sign. So if you have high blood sugar, the early warning sign is too much urination because the high blood sugar makes you just go to the bathroom all the time. If you have pancreatitis, then it's abdominal pain, nausea, vomiting would be the early warning signs. And thrombosis, it depends. If it's thrombosis in the brain, many patients start out with a seizure. So it's pretty bad when you start out with a seizure, especially if the patient's already gone home. So it's very
It makes the treatment more complicated. I think it's looking out for the important history points will help identify the warning signs, definitely. If asparaginase is modified from the treatment plan or stopped early, does that affect the remaining course of treatment or the prognosis of the patient?
It's a disaster, actually. So imagine in the 70s, before we had asparaginase, 50% of people with acute lymphoblastic leukemia were cured. Adding asparaginase brought it to 70. So it's a 20% bonus in survival. So now imagine that bonus is taken away and you're back minus 20. So the worst side effect of asparaginase is relapse when you don't get enough. And so that's why we're willing to put up with the blood clots and the diabetes and the risk of pancreatitis, because plus 20%, most of us would take a chance on some side effects if we have 20% chance we're a cure.
So is there any other therapy that can substitute asparaginase, or no, we just stick to it and hope for the best?
Well, and people have tried different things. The trouble is every other treatment has already been pushed up to the max. So if the asparaginase is taken away, you can't go above the max on some of the other ones. So it's a unique one because it got added on to the other ones when they were already at their max. So that's the problem, is there's nowhere to go, except there are various types of asparaginase. So if you have an allergic reaction to asparaginase,
Or they can modify their
there's
type.
cyclic asparaginase. But if you have a pancreatitis, severe pancreatitis, then no asparaginase can be given. So you can't switch to plan B or plan C.
Thank you very much for clarifying that. It makes more sense now. What improvements, so looking at the future, what improvements or innovations are you most hopeful about in the field of pediatric oncology or related to asparaginase toxicity?
So it's interesting. The story of acute lymphoblastic leukemia is the best story in cancer care ever, because in 1978, asparaginase was invented and first used in doulas. The cure rate went from 50 to 70%. Since 1978, without any new medicines, the cure rate is now up to 90%. So from 70 to 90, there's no new medicine. Just using each medicine exactly the right way, getting the toxicities to the minimum, combining medicine A, B, C in exactly the right sequence.
Tailoring it well,
Everything perfect got us from 70 to 90. And then blinatumomab came along, which got us from 90 to 97%. So that was the case of a new medicine. 2022 was approved for frontline use. So the last 3 years, we've had this. So we went from 50 to 70 with asparaginase, from 70 to 90 with perfect use of everything, from 90 to 97 with blinatumomab, and only 3% to go.
You'd
be curing
there is the goal of curing every child with ALL, so we're getting closer to that.
And the adults are coming up fast. They're only about 20% behind the children. And it's, of course, harder to treat adults because they have so many other health problems and old age and comorbidities, exactly. But the future is to use this example from acute lymphoblastic leukemia children and have every single patient, every baby, child, teenager, young adult, old adult, elderly adult, they all need access to care, to this perfect care, and access to research so we can move forward fast. Most children with acute lymphoblastic leukemia are enrolled in a clinical trial. So they're not only getting the best care, the best organized care, but they're learning for the future to help future patients with this.
Thank you very much, Dr. Chavez, for the great insights you've shared with us and for the hope you presented about the future of pediatric oncology. It was lovely having you. Enjoy the content.
Thank you so much. We will get there together. Bye.